Hi everybody, and welcome to the Rural Doctors Association Destination Rural webinar, talking about not just doing regional internships but rural placements as interns and junior doctors, and hearing from our panel about not how they survived the experience but how they've actually thrived as a result of that experience. Before we get started, I'd like to acknowledge the traditional owners of the land we meet on tonight across the great nation of ours, and pay my respects to elders past, present and emerging. I'd also like to acknowledge many of our rural colleagues and people in our rural communities who are going through a terrible situation at the moment with the bushfires, and certainly, you know, our thoughts and prayers are with them, and we are working hard to ensure that these communities are provided with lots of support, not just in the immediate response but in the long-term medical service provision. So with no further ado, I'd like to introduce our panel. We've got four amazing doctors. We've got Dr. Ben Dodds from Tasmania, Dr. Marian Dover from New South Wales, and from Victoria we've got Dr. Louise Manning and Dr. Dan Wilson. So we'll get started, and we'll start with Dan, and just a little bit of an introduction, your name, and we'll go through each of the panel members, but we'll start with Dan. Your name, where you currently live, and a little bit about where you're heading in the next, few weeks, and also a little bit of background about your family. So Dan?
Hi everyone, I'm Dan Wilson. I'm a PGY2 doctor currently working at Ballarat Health Services. Right now I'm actually on locum in Mildura in the far northwest of Victoria. I grew up in mid-north coast New South Wales in a small town of about 10,000 people, and grew up in a reasonably small family, and I've really enjoyed kind of the small town life and luxuries of a small town. And this year in 2020, I'll be starting a brand new job that's never existed before, working as the first hospital registrar in East Grampians Health Service in Ararat. And I'm really looking forward to that. That's me.
Okay, Marian?
Hi everyone, my name is Marian Dover. I'm in Taree at the moment, mid-north coast of New South Wales, probably close to where Dan grew up. I am currently doing obstetrics training about to finish my 12 months, and I'm moving on to my GP training, and that will be in Scone, which is also in the Hunter, New England area in New South Wales. I would say that I'm probably from the city. I grew up in Egypt, and my parents are still in Sydney, and I'm still trying to convince them to leave Sydney, and they haven't. But I've been rural since my final year of medical school, and I have pretty much fallen in love with everything rural, and plan to die rural. It's pretty much in my blood now. So, yeah.
And we'll go to Louise.
Hi everyone, I'm Louise. I am currently PGY3, will be moving in to PGY4 in a few weeks' time. I, similar to Marian, have been doing my advanced diploma through RANZCOG, or the College of LG, so that I can become a GP obstetrician. And in 3 weeks' time, I'll be moving into community practice in Castlemaine in Victoria, which has a population of about just under 1,700, has a small health service there where they continue to do some deliveries, and they have a small urgent care centre. I'm really looking forward to doing that, and going across to another small town, Maryborough, where I'll hopefully be able to do some caesareans with my mentor, who's a GP obstetrician who's working both at Castlemaine and in Maryborough. I grew up in a small town called Woodend, which is about halfway between Melbourne and Bendigo in Victoria. And after my 5-year stint in Melbourne during my university days, I decided that that was enough, and I was very happy to be part of the Royal Clinical School in med school, and have interned and worked in Bendigo since 2017.
And Ben.
Thanks, Peter. Hey, guys, I'm Ben. I'm down in Tassie. I grew up in a town called Ulverston, which is on the northwest coast of Tasmania, about 10 or so thousand people. I went straight from school down to Hobart to study medicine and then came back up to the northwest coast for my clinical years at the University of Tasmania. For the last 2 years, I've been working as a junior doctor across Burnie and Devonport. And I'm very excited to start a palliative care position in a couple of days' time as part of my ACRM training. And I'm very involved with the Rural Doctors Association in Tasmania and in Australia. Thanks, Peter.
Okay, well, a number of people that are on the webinar tonight are about to, or in the midst of intern orientation or about to commence their intern orientation. So just a little bit about, for each of the panel members, where you did your internship and why you selected that location, as well as maybe a little bit about what was your biggest worry, sort of going into this time of year, you're just about to start an internship. What was your biggest worry? So we'll start with Louise.
So I may have jumped the gun a little bit. So I have been at Bendigo Health now since my internship in 2017 and have loved it so much that I've stayed on for 3 years, and I'm going to be continuing to do so on a fortnightly basis, despite going to uni in 3 weeks' time. For me, having studied rurally, having grown up rurally, I knew that I didn't want to work in the city. So for me, it was really about the weather and the kind of training opportunities that I would get. So I kind of narrowed it down to Bendigo or Ballarat within Victoria. And given that the weather is so much nicer in Bendigo, that was an easy choice for me. The thing that I worried about the most, I think, is probably a common theme, which is that I was going to kill someone. And I had some wonderful people come and speak to me in my intern orientation who were like, no, people will die, but it won't be your fault. So the thing that I like to remind people starting internship, and for those interns that currently started in Bendigo this week who I've already had a chance to have a chat with, I like to say that you're expected to know nothing and you just need to be efficient and hardworking, and everybody else will make the decisions for you. That's what your registrar's for. So don't have that fear that I did, that you will kill someone. It's never on you. It's always on someone higher up the chain. So don't worry.
Thanks, Louise. Some good advice. Dan.
So I did my internship in Ballarat, and like Louise, I was tossing up between a large regional health service, having done my clinical school actually in a metropolitan centre, because I knew that I probably wouldn't ever return, but I didn't want to step out to something too small too soon. And obviously I chose Ballarat because it's got far better culture. And I guess the other reason that attracted me to Ballarat, like I kind of insinuated, was I was a bit frightened about going into practice and having responsibility for patients' care, and I was quite frightened of entering essentially something that I'd never done before, stepping on from a student to a doctor, having the responsibility to prescribe, to order, to refer, and those fears were certainly allayed once you start working. You have a very supportive team around you, and I'd certainly heard of that occurring at Ballarat, and that's why I chose to do my internship there.
Okay. Marian, what was your time like?
So I knew that I was going to be in New South Wales, and I chose to do my internship and residency to 2-year contract in New South Wales. I chose to be in Wagga. My biggest worry, I had a new baby at that time. I had a 5-month-old. And I think my biggest worry was that I wouldn't be able to continue breastfeeding. I wouldn't be able to juggle home life and work life, knowing that internship is a pretty tough slog. And I guess from there, I wanted to choose a hospital that was going to be really supportive and understood the family situation that I was in, and somewhere where they would be really supportive of my career aspirations, would be supportive of making sure my family is included into the community. And we picked Wagga because there was a really great church there that I knew we'd be able to integrate and, feel part of. My other biggest worry, I guess it's that classical imposter syndrome, being someone who, prioritised family in medical school to academic strength. I was always worried that I would be, identified as the doctor who didn't really do very well in medical school. And in many ways, I think it was probably surprising that the people that do really well in medical school are not always the ones who become good junior doctors. And I guess that sort of leads on to what you should be doing to prepare for internship. And the answer is just make sure that you care about patients. If you're someone who's going to know that a patient is unwell or can identify someone that's deteriorating, and you escalate that and you care enough to follow it up, that usually is what makes a good junior doctor. So, yeah, thanks, Peter.
And Ben, we'll go to you now.
Thanks, Peter. So I chose to do my internship in Burnie at the Northwest Regional Hospital because that's where I'd done my final 2 years as a medical student, and I was very comfortable with the environment, very comfortable with the systems around it, knew some of the doctors that worked there, and I thought it would be an easy transition into internship, or at least make it a bit easier for me. A family also live up here, so that was a big bonus as well. I think the thing that I worried about the most, especially when starting, was that I wasn't going to be confident in my own abilities, and there'd be a lot of second guessing and things like that. And I didn't want to be that person that will go see a patient and then sit down and think, I have absolutely no idea what's wrong with this person. I can't think of any differentials at all. Where do I start again with something as simple as chest pain? But after a few days of working in the emergency department, I realised that actually I had learnt something over the last 5 years, and that I was able to put things together and bring things out and think things through clearly. I did worry a lot about how I would be seen when I was presenting to the consultants and to other doctors, and what was I going to say? Was I going to say something dumb, or was I going to say the wrong thing, or was I going to annoy them? But you kind of get a bit of a sense of what's important over a little bit of time, and you become more fluent and a lot better with a little bit of practice. And you get better at thinking things through and prioritising different jobs and working well with other members of the team, such as the nurses and the allied health staff. And it becomes quite enjoyable very quickly, and it's fun to go to work and put everything you've learnt into good use.
Just on the prioritisation, Ben, you mentioned, are there any tricks that you could, or any suggestions you could make about how you do prioritise your work? Just to sort of give people a bit of a guide, or anything that you learnt that would be useful.
So I think being prepared is very useful. So you have to get to work on time. You have to make sure your morning list is up to date, know who your patients are, have a bit of a clear idea of who might be going home throughout the day, so you can get things ready and sorted. I'm a bit of a list person. If I don't write something down, then I'll probably forget to do it. So it was always on to me to make a list or just put a little box next to the patient on my list and be like, yep, got to go back and rewrite that drug chart or something as simple as that. And if you're not sure, you've got competing priorities, use the people around you and ask them for help as well, and say, do you have a minute to maybe go and check this thing out for me and see if I need to go now, or can it wait half an hour for me to finish what I'm doing? And you'll suddenly go from being a medical student to an intern, and you'll have medical students with you, and you'll think, what do I do with them? I've got no idea. I was only a medical student a month ago, and now I'm expected to be teaching them. So it's also useful to have them in the workplace and to help them and to utilise them to help you with work.
Thanks, Ben. Okay. As an intern or a junior doctor, when you're particularly at regional hospitals, you're often required to go or asked to go and do rotations into smaller rural hospitals where lots of our members are. And interested to hear from each of you about what your experience was in relation to those rotations, the sort of support that you were given, whether there were any additional challenges, or what was the best thing about those rotations into the smaller hospitals or into the smaller communities, and what was either the unexpected or maybe one of the most challenging things you experienced on that rotation. Ben, we'll go back to you to start with.
Thanks, Peter. So in my internship in 2018, it was the first year of the Junior Doctor Rural Innovation Fund, which meant that interns could go into general practice and primary care for the first time, which was a little bit different than the schemes that have been run before. So we were given the option of rotating out to 5 different rural areas in Tasmania, where there were essentially 2 doctor towns with a general practice and small 10-bed hospitals with GP-run emergency departments. So I chose that opportunity because I'm interested in the rural generalist pathway and have since decided to pursue that through ACRM. And I thoroughly enjoyed that experience. I found that even as a junior doctor and being rotation 2 very junior doctor, it was a great level of responsibility within a really good realm of support from 2 experienced rural generalists in Queenstown on the west coast of Tasmania. So it was exciting to be at the forefront of most things in the hospital and the acute things in the general practice, but to have really good support along the way from these doctors as well. I think the things that were unexpected was how sick people can get very quickly. And we hear about this a lot with our rural towns, and you don't realise what luxuries you actually have in the regional hospitals until you're looking after someone that's very sick in a regional town that's relying on some very simple pathology and imaging and long retrieval times. So it gave me a greater appreciation for what you can achieve based on clinical knowledge and experience of those GPs and doctors that you worked with, and taught me a thing or two to take back to my regional centre and helped the other doctors there understand what these little hospitals can and can't do, and what are reasonable expectations if we're receiving patients there or returning them home again.
Okay, let's go to you, Louise.
Thanks, Peter. So in my internship, I did a 3-month general medical rotation at a small town called during the non-tourist season is relatively small, but the numbers swell in the summer months. Being on the Murray, there's a lot of holiday makers that come there, and there's a number of big events throughout the year. And there's these huge number of people come through, particularly when the Gillikin youth muster is on as well. I went to Echuca partly because I said I didn't mind going, and there was a number of people who really didn't want to go. And I'd been there as a medical student for a year and I had a really positive experience. So I was quite happy to go back. And it meant that I got to do, as part of the deal that Echuca had with Bendigo, is that I would get to do an oncology rotation as well. And I was quite interested in picking up as many specialty medical rotations as I could, knowing that I wanted to head out into general practice. So I thought the more extra exposure I could get earlier on, the better equipped I'll be eventually when I did go out into the community. So good thing about being in Echuca is that accommodation was provided at the hospital, so I didn't have to worry about finding somewhere to live, and I only paid about $5 a week in terms of rent. It was quite challenging, and I know that they've changed a number of things about the experience there now compared to when I was there. At that time, there was 2 medical teams based around the 2 major practices in the town, and you'd have your GP VMOs come in and ward round with you in the morning, and then the rest of the day you were essentially left to fend for yourselves and look after your patient load. After being on take, it could be really quite busy, and at that time there was one medical registrar, which is someone who wasn't actually on the physician training program, who was probably only either probably PGY 3, 2 interns, one from the Austin, who I was lucky that was a friend of mine from med school, so we had a good time, and myself, and then one resident from Bendigo as well. Problem is that the registrar didn't work every shift, and essentially were just another resident. And on certain days when the registrar was off, or when the HMO was off, I'd often be left covering all of the patients on the medical, surgical, paediatric and maternity wards by myself. I think this has changed a bit now, but I do remember finding it relatively challenging, not so much the patients on those wards, but I was also in charge of a 6-bed HDU unit, which, whilst at the time I didn't think I was particularly interested in critical care, I found that it was actually quite interesting, and I learnt heaps. One particular scary experience, but a great learning experience for me, given that I just come off a cardiology rotation, was that I had a young woman who couldn't get out of SVT. We threw so many medications at her and it just wouldn't slow down. And after me being on the phone call to one of my own consultants who was in Bendigo every single day for advice, he said, "Oh, Louise, you're just going to have to cardiovert her." So I called one of the GP anaesthetists in. We took her around to the little ED treatment bay, and yeah, I got to cardiovert this woman, and we fixed her. So that was really cool. And I can't say that I would have ever had that opportunity to do so in a large regional, let alone a metropolitan hospital. So whilst at times I felt a bit stretched, and potentially whilst I was supported through the GP VMOs externally, there wasn't really anybody on site very often. I still had a really good time.
Marian?
Yeah, so similar to Ben, I was given the opportunity to do a general practice rotation as an intern, and I ended up going to a town that's really quite small, of a population of only 2,000, about half an hour from Wagga. And in that rotation, I think the thing that I enjoyed the most was, I guess, a town of 2,000 people. It's very hard to be anonymous in a place that small. And there were lots of patients coming in going, "Oh, you're the new doctor. Are you staying? Are you glad to be here? Can we keep you?" And it was really great because people would like bring me things from their farm, and it was such a lovely community feel. Unfortunately, I did have to leave after 3 months, and it was really sad. But being able to do a general practice term where you are also sort of running the emergency department and looking after the local nursing home and looking after some of the inpatients that were there, it was a really unique experience, and I don't think many interns would be able to say that they have done anything like that as an intern. I thought that was really, really fortunate for me to be able to do that. In terms of the worst part of the experience, I'd say it just felt like I was a little bit behind once I did get to the hospital system. Once I moved on from like the general practice rotation and then started my general surgery rotation, a lot of people knew the processes in the hospital and I didn't, because I seem to be the kind of person who just likes to jump from one area to another local health district, and I like to make things challenging for myself that way. But I picked it up fairly quickly, and there was always lots of support around, and I think the number of places that I've been able to work in has made me a pretty well-rounded doctor, and I've been very grateful for it. So, yeah.
Dan, we'll go to you for your comments on this.
Thanks, Peter. I actually didn't rotate to any smaller rural hospitals during my internship. And in fact, that was part of the reason what drew me to Ballarat for the internship, because I didn't have to rotate anywhere else. I really wanted to consolidate my skills in a known supported environment, because like many of our viewers tonight, I was very concerned about not being supported. And this, I should say last year, during my PGY2 year, I've locumed to two smaller towns, both Mareeba in Queensland and Mildura in Victoria. And the most challenging part of going to a smaller rural health service is similar to Marian, is having to learn all of these new systems again and starting from scratch, both not knowing anyone and not knowing any systems. But again, the benefits being that you are absolutely welcomed with open arms, and similar to Louise, you get a far greater scope of practice, and you're supported to do things that some of the advanced trainees on specialty programs are probably doing at PGY 7 or 8. You might get to taste that one activity that's generally reserved for them, and you get to trial that in a small rural town. Thanks, Peter.
Nice, Dan. Okay. Here, just some pearls of wisdom, I guess. What's something you would tell with everything you know now, what would you tell your sort of first day intern self? And yes, some advice you would give to your first day intern self if you could go back. We'll start with Dan.
Sure, thanks, Peter. Number one, breathe. You can actually take time to think and slow down. Number two, eat. Number three, drink. Number four, remember that you're human and you also make mistakes. But those mistakes may seem huge to you at the time. You might simply forget to write a note or write something wrong, or you've ordered the wrong test or forgotten to order a test. But don't forget that those small errors are how we improve, and you'll continue to get better with time. And number five would be to remember that you've always got support, whether that's nursing staff, allied health, doctors, friends, family, you name it. Thanks, Peter.
Okay, just for everybody online, if you want to ask a question, up at the top of your screen is a little blue icon with a hand. If you click on that, you can actually type in a question and we can read it out and get the panel members to answer it. So just remember that option is there if you've got a burning question for the panel. But we'll go to Marian for some pearls of wisdom on to your first day intern self.
My biggest advice would probably be find people that are keen to teach and put your hand up for everything that they offer for you to do. I remember in my probably in my first week of my surgical rotation, the surgeon asked me if I wanted to close up the wound. That we'd done a laparotomy, and he asked me if I wanted to close up, and I was like, oh, I'm not really sure I'm ready. And he was really encouraging and pushed me, and I managed to do some of it, and I was really proud of myself. But that's the biggest thing. I think if you're an intern or you're a junior and you're in a rural hospital and you've got that one-on-one time with a senior consultant or someone who's very qualified, you've got that license to not know what you're doing, and it's okay to say I don't know, but if you walk me through it, I am keen. And I think that would be my biggest advice. Don't shy away from opportunities. People don't expect you to know everything, and they certainly don't expect you to be confident, but they are willing to teach, and that's something you should really take advantage of. So, yeah.
Nice. Ben?
Yeah, thanks, Peter. So I'll echo a little bit of what I said before, is that you do need to trust yourself, that you've made it this far and you've graduated as a doctor, so you do know some things and you are pretty clever, so you do have that clinical knowledge that will guide you. But if you're feeling unsure about something, then it's okay to ask questions. And you might just be asking the other interns that you're with, hey, what do you think of this? Does this sound right, or does this look a bit weird? And then if they agree, oh, I don't know what I'd do with that either, then that's a pretty good reason to go and ask a registrar and ask a consultant. I think my one top piece of advice is that if you're asked to see a patient or you're asked to do something for a patient, go and see the patient, because there are many things that get missed, or deteriorating patients that become more unwell because we just write them up something to stop them vomiting, or we give them some Panadol for some fever and we go, yep, tick, done that job, off I go to the next one. But you do actually run in and see some really sick people that no one else has noticed, and you might be the first person that actually sees it and does something about it. So I think that's the best tip, is if you're unsure or you're asked to do something, that you go see the patient.
Louise?
Okay, so I guess there's two things that I really wish that I could drum into my first week intern self. Well, three things actually. One, it's going to be okay, and you deserve to be here. Two, prioritize meals. You know you get hangry if you don't eat. You need to be able to concentrate and make sure you eat lunch. And three, trust your gut. If you don't feel right, or you just feel that you can't quite put the finger on what is wrong with this patient, but you're just a bit worried or you're concerned, just call a med call. Just ask for help. And if anybody tells you off for calling a med call, that's on them, not on you, because if you've got genuine concern for that patient, then you should 100% call for help, and because the patient's interest is in your hands, and if you don't, then who will?
Thanks, Louise. Before we leave you, Louise, we've just had a question from one of the people attending the webinar. What are some tips for prescribing? So, Louise, I'll go to you first.
So the e-therapeutic guidelines and the AMH are your best friend. Until you've memorised a few things, you should be looking up the doses and the routes for every single drug you prescribe, because once you sign your little name there, it's on you, and which is initially quite scary, but by backing yourself up, by making sure that you're following evidence-based guidelines, it can be quite liberating. One thing that I did have was a little cheat sheet that I kept in my little body bag that I wore every single day in internship, which just had some common doses of, some doses for the common antibiotics, pain relief, antiemetics, and a couple of other drugs on there too, just so that I had something quick at hand in case I didn't know exactly what I wanted to write. So that can be helpful if you've got a few things that you think you're going to be prescribing a lot, and I'll tell you those will be things for community-acquired pneumonia if you're on med. Those will be aperients if you are on surgical as well as analgesia, and maybe some antipsychotics if you're doing psychiatry or some antidepressants. And just have a little list that you can have on your person. And if you're not sure, always check either the e-therapeutic guidelines or the Australian Medicines Handbook, which you should be able to access through your hospital for free.
Thanks, Louise. Marian, do you have anything that you'd like to add to that? Or you just think that was good advice?
That was great advice, Louise. I'm married to a pharmacist, so he always likes to comment on my scripts when they get to him. But I think the other great advice is it's okay to ask the nurses or the midwives. Usually they're a really great sort of resource for advice. Like a common sort of line that I would use when I'm new somewhere or I'm not really familiar with a particular presentation. If the nurse comes up to you and says, "Hello, can you please chart some pain relief for this lady who's just had like a knee replacement?" and you go, "Oh, I haven't actually done that before. Do you know what's commonly prescribed in this situation?" And usually they're really helpful. They'll be like, "Oh, normally we give them like endone," and obviously look it up before you write it down. But like they are a really great resource. Don't be afraid to like have that humility to say, "Oh, I haven't actually done this before. It's my first week here." I said that for like the first 6 months. It's my first week. I don't really know, but what is normally done in this situation? And they'll go, "Oh, yep, we normally give like oxycodone, or we give like ondansetron if they're vomiting." So that's usually helpful. The other really helpful app, if you don't have it, is the MIMS app. I have it on my phone and I downloaded it day one of internship. It actually tells you what form each medication comes in. So it'll tell you that ondansetron comes in 4 milligrams and 8 milligrams, and it comes in a packet of 10. And it makes it really easy when you're writing scripts or when you're doing dosages for a med chart. So that's always a really good resource as well. Thanks, Peter.
Thanks, Marian. Okay, we'll go back to you, Louise, just in relation to your time in either regional or rural communities, about maybe your most embarrassing or your most memorable experience. I guess just to give people who have joined us tonight on the webinar a sense that, you know, if something does happen, that they're not alone.
Probably got too many embarrassing stories to think of, and I can't think of one particularly spectacular one at the moment, which is a real shame. I guess for me, the moments that stand out, particularly in my internship, actually come from my oncology rotation, where I was lucky to really get to know a number of patients throughout their cancer journey, and was privileged enough to be involved in their care up until end of life. And there were 2 patients that come to mind who were so grateful for the care that my team provided. That one was a country singer, and he brought in a big box of all of like his EPs in CDs so that we could all share in his joy of his music. And then I had another patient who was a really keen photographer, and he brought in all of these beautiful, not so much greeting cards, but like the cards that you might give to someone as a thank you, or with a gift of his beautiful photographs on them. So that's something that's I find really touching, and is more possible in a smaller health service, I think, when you've got a smaller team. And it's great to develop some sort of relationship and continuity with these patients. I wish I had a good embarrassing story for you, but I just can't think of one. I'm so sorry.
So nothing about nasal prongs?
No, that's unfair, Peter. We had a discussion before the webinar started, and I was speaking about airway management and putting nasal prongs on backwards, and how as a junior doctor it's always terrifying the first time you have to put some nasal prongs on because you're never 100% sure which way they go. And I was doing a workshop with some new interns today, and they all did a pretty good job, but there was only one person for the whole day that managed to put them on the right way first up. So that's definitely something that I've experienced before as well.
Okay, Ben, let's go to you for your most memorable or, slightly embarrassing event.
Well, mine's going to be warm and fuzzy and not embarrassing to save my face here. So to go to Queenstown, which is just a 1,500, 2,000 person old mining town where the mine doesn't actually work anymore, was a real privilege because you got to know that community very well. And similar to Marian, it was very hard to be anonymous in a town with one supermarket, one service station and one post office. My most memorable moment was connecting with a patient unexpectedly, and that occurred by him falling off a ladder from a very high height and coming into our small emergency department in an ambulance, and me freaking out a little bit that he could have all sorts of weird trauma and maybe I'm going to have to stick a needle in this guy's chest and decompress his pneumothorax. But it was fine. He didn't actually have any injuries at all and he was very happy. But I did decide that he needed to go up to our regional centre about 2.5 hours away and have a CT scan of his neck because of the height. Which is, it's a big thing for people in small communities to leave, but he graciously accepted that advice and transferred up to Burnie. I saw him a few days later. He came back to the practice and just for a review, post his emergency department discharge and for some ongoing analgesia. And then about 2 weeks later, he came back and I wasn't exactly sure what he was coming back to see me for. And he sits down and he goes, I didn't mind you. I thought I should come back and have some tests. I haven't actually been to the doctor in about 4 or 5 years. And I know I've got high cholesterol and, I've probably got problems with my blood pressure as well. So I should just have that checkup that I've been meaning to have. So it was quite lovely to connect with the patient on that level, and that reaffirmed to me that I wanted to do rural generalism, where I go from one moment sorting out trauma to talking to him about primary prevention and blood pressure and cholesterol control and absolutely everything in between all day, every day. And to experience that as an intern was quite a privilege, and I think that was probably my most memorable moment of internship.
And we don't mind you either, Ben.
But you'll invite me back, thank you.
We will. Marian.
Yeah, we don't mind you, Ben. My most memorable experience is probably also one where I felt like I made a difference in a patient's life. There was a lady that was on the ward and I got called to review her for a fever, something that you get called for all the time. And this was when I was like one of 2 junior doctors looking after a 250-bed hospital, which is brutal. Like before those shifts, you like drink your 2 glasses of Barocca and you're going to be go, go, go for a good 12 hours. So when I was called for the first review, I was like, it's okay, just, I'll do a septic screen and give her some Panadol. Call me if she's still febrile. And normally that fixes it. It fixes about 90% of people who are febrile. But on this particular night, after I'd done my 20 cannulas and my 35 clinical reviews, they called me again and they're like, sorry, her temperature's still 40 degrees. Can you please come back and review her again? And I was like, okay, this time I should probably take some time to see what's actually going on. So she was a 53-year-old lady who had metastatic breast cancer, and the team that was looking after her had already put her on Tazocin for 24 hours, and she was on regular paracetamol and still was febrile. So I knew something wasn't quite right. So when I went and talked to her, I was like, so trying to think of my differentials, like, have you got chest pain? She's like, yeah, I've had chest pain for, 30 years because I've got breast cancer. So I just assumed that it was like cancer pain. And I was like, oh, okay, let's do it. Let's do an ECG. So we did an ECG, and it was like sinus tachycardia. She's febrile, sinus tachycardia. She's been in bed. She's got metastatic breast cancer. You think, well, I think we should probably do a CTPA. This might be a clot in her lungs. And sure enough, she hadn't been on Clexane and her CTPA lit up everywhere. She'd had like a saddle embolus and was probably close to decompensating. She was already on oxygen because of her breast cancer, and people just assumed that that's what was happening. And when I showed up the next night for my next brutal shift, she saw me in the corridor and she was like, have you been doing this for a while? And I was like, yeah, totally, like 50 years. No, I haven't. And she was like, yeah, I think you did a really good job yesterday. And like, I don't think anyone else would have picked up on what was happening. I had lots of clots in my lungs, and apparently that was probably not good for me. And I was like, yeah, you're welcome. I felt really good that day. So that was my memorable experience as an intern.
Just before we go to Dan, if anyone has any questions, don't forget the little blue hand at the top of your screen, and we can hand over to the panel to ask or to answer your burning questions. So, but first of all, we'll go to Dan. And what's your memorable experience, Dan? I'm sure you've got one for us.
Oh, look, everyone's gone for warm and fuzzies, and I think you're bound to have those experiences where you connect with a patient, and you'll have a patient admitted under your unit almost for your entire 12 weeks, and you become so connected with them and you become part of their life, and you follow their story even beyond the rotation, just through the medical community. But there's plenty of embarrassing moments all the way through from dropping the entire ward round's coffee on the floor in front of the boss and all over my clothes, all the way through to calling one of my bosses in the emergency department mum. So my internship was certainly a comedy of errors, but you have to look lightly upon all of those things that happen throughout internship. They form good memories. Thanks, Peter.
Well, Dan, you must have done something right considering you were named Junior Doctor of the Year in Victoria. So I don't think it was a complete comedy of errors. You've done really, really well. Okay, so I'll just have a look at the questions if there are any coming through, but remember the blue hand. But just in relation to the Junior Doctor rotations, I'll go to Marian first, but do you feel like you've missed out on anything, or if there's been a major challenge as a result of doing either a regional internship or a rural rotation? I'd be keen to hear your thoughts and for you to share those with the people online. So I'll go to you first, Marian.
Thanks, Peter. This is like one of my pet hates, all of the myths and misconceptions that are out there about going rurally. And it's something that you hear all the time. Oh, you went to Lithgow in the Blue Mountains for your junior doctor years. You probably didn't get to do much. It's absolutely not true. It's the total opposite. I like to tell people what I was doing as a final year medical student when I was in a rural area, and I was in theatre when I was doing my surgical rotation. I was the only student that was in theatre. There were no registrars, there were no interns, no JMOs. It was just me and the consultants, and there was a surgeon and an anaesthetist. So when the patient would come in, I would cannulate them, and then I would bag them, and then I would intubate them, and then I would scrub in to assist the surgeon in surgery. So no, you definitely don't miss out on anything. You get to do a whole lot more than some of your colleagues in the city. Intubation is a skill that you learn as an advanced trainee or as a anaesthetic registrar once you've gotten onto the rotation as a PGY 6 or 7. And I was doing it as a medical student, and I've done many since. So I think that's a huge misconception that's out there, and it's very much not true because you get that one-on-one with your consultants. The other thing to remember is if you're a junior doctor at like RPA, which is a big hospital in Sydney, just think, is your boss going to know you? Is your boss going to remember you? In a rural area, most of the GPs or the consultants that are around are on national boards or they're national examiners, and their references are going to be so personal because they know you, they know what you want to do, they know what your career aspirations are, they know what your ability is, and they've got your phone number. Most of them have, invited you over to their place, so they get to know you really well. The quality of your references is so much stronger, and your clinical experience is going to grow exponentially in a rural area compared to being in the city. So, yeah, that's my 2 cents worth.
Thanks, Marian. Let's go to Louise for her comments on this.
I 100% agree with Marian. I think that I've been able to have a huge number of experiences that a lot of my colleagues who've either studied or worked in metropolitan areas just have not. In only 2 years as an intern and then as a PGY2, I was able to do all of the specialty medicine rotations that are on offer at Bendigo Health. So I was able to do oncology, cardiology and renal medicine, which is something that even people aspiring for basic physician training just don't get to do. I've been able to do much more procedural work and particularly anaesthetics as a medical student. I've also been lucky enough to do lots of intubations and provide sedations. I've managed to cardiovert many people through my cardiology term, and then, as I mentioned earlier, during my time in Echuca. I've really been given the opportunity to develop my leadership skills and upskill in a way that has pushed me, but I've felt in a supported way by being in a large regional centre, and I've felt that really prepared me for what I want to do in terms of rural practice. I know it can be challenging if you're not particularly interested in a career in general practice or rural generalism, because some training programs are limited by where you can get accredited training spots. But RDAA are working on this space, and I'm sure that as the new interns listening today progress throughout their careers, it will become easier and easier to undertake more and more of non-GP specialist training programs in particular regional centres. And RANZCOG, or the College of ONG, have already made big leaps in making their provincial training program and trying to promote rural practice as not only viable but exciting and diverse. So if anyone tells you that they didn't get to where they wanted to be by working rurally, I think that's mostly a lie, but it can be challenging when you are interested in non-GP specialties to be able to get some of those accredited positions. But I ask you, don't give up hope, because there's a lot of work going on in this space to try and make that more and more achievable going forward.
Okay, thanks, Louise. Dan, you suggested people breathe, eat and drink, and one of the questions from our watchers tonight is, how do you do that? How do you make sure that you are going to get something to eat when you're on duty, when you've got a long shift? Just some hints to make sure that you find that time for yourself to eat, breathe and drink.
Yeah, thanks. Thanks to, I think it's Jess who's asked that question. It's a really sensible question because I remember shifts when the common page is this patient has really low urine output, and you review the patient and you think, I haven't even weed today. So some tips for making sure that you also act as a human. On many of your jobs, you'll be doing ward rounds in the morning, and then hopefully you'll sit down for a paper round or some coffee. That's also an opportunity to just say, hey, I'm going to go and grab my lunch, and you can have lunch at the paper round. And I guess the other setting is when you're doing a cover shift, where things, like Marian said, it's go, go, go. You need 2 Baroccas just before you even start the shift. And I do remember vividly just going to the wards, and the nurses will notice how tired you are. Just ask and say, I'm really exhausted. I haven't even brought my own lunch today. Do you mind if, are there any patient meals left over? Could someone please get me a drink and I'll take 2 minutes to sit down, or I'll go to the bathroom just before I see this patient. So yeah, using time when you've got the opportunity, so at the end of ward round, but also letting others know if you do need a break, because your allied health and nursing staff will definitely accommodate you to have some rest. Thanks, Peter.
Thanks, Dan. I used to manage a rural hospital, and we used to tell our junior doctors that would visit always make friends with the kitchen staff, because then they always look after them.
Yeah.
So just go to Marian. We've also had a question, I think, from Jess in relation to any hints for discharge summary. So I'll go to Marian first, and then I'll flick over to Ben as well.
Thanks, Peter. And it's a great question, Jess. Lots of junior doctors ask this. I think what you need to sort of try to remember is, if you are the GP seeing this patient, what pertinent information do you need to find out really quickly? The fact that a patient has a discharge summary when they leave hospital is amazing, because that means that doctor has actually prioritised that as a task when a patient has left hospital, and recognised that it's a handover document that's really important. In a discharge summary, basically what a GP needs to know is, when was my patient in hospital? Why was my patient in hospital? What have you done to them in hospital? And what do I need to do now? They're sort of the important things that need to be communicated to a GP straight away. As a junior doctor, it can be hard to sort of filter out all the other information, especially if a patient has had a prolonged admission. And I think my record was a patient who'd been in hospital for 230 days, and I had to summarise that in a discharge summary. And it's so tempting to be like, make sure you tell the GP about day 57 when he had some back pain and it was nothing. But I think if you remember just those basic things as a GP when they're seeing them, what do I need to know? And usually it's the plan that's the most important thing, and what medications have you changed. So try to sort of have that mindset when you're writing a discharge summary. It doesn't need to be long, and preferably please don't make it long, because then it makes the GP's job harder. That's my advice.
Ben, do you have anything very quickly to add? Because I'm just conscious of the time, and we're certainly coming close to the end of our time.
Yeah, thanks, Peter. I'll agree with what Marian says. It's a summary. It needs to be concise. It needs to be what's going to happen next and what medications is this patient on. The only other thing I would add is, don't be afraid to use the phone and call general practices and call GPs, especially if you need something within the next 3 or 4 days. You know, we're sending this patient home, but they need another blood test to follow up their renal function because it wasn't quite back to baseline yet. So if you want something like that to happen, you need to communicate that verbally, especially if you're not going to get to the discharge summary on the day of discharge as well. And GPs really enjoy being included in the discharge planning, being phoned, and being part of the process. So definitely, if something's been really tricky, or if a patient has died unexpectedly, maybe you give a phone call to the GP and just give them a heads up. So the first time they know about it isn't when the patient is sitting in front of them and they're trying to read a 5-page discharge summary.
Thanks, Ben. Well, I'd just like to say thank you to our panel members. I think you've provided some excellent advice and some excellent insight in relation to being a rural or regional intern or junior doctor. So thanks to Marian, Ben, Dan and Louise. Really, really appreciate your participation tonight. Also, thanks to everyone who's joined us. You will go into the draw to win a paediatric stethoscope, which is exciting. But I think, you know, as our panel members have said, trust yourself, you know, ask lots of questions and just, yeah, take some time. So enjoy the year. If you need anything, you know, we're only a phone call away, and there's lots and lots of people around who are really keen to have you on board and really keen to support you so that you have a great year ahead. So good luck, and thanks for joining us tonight. Thank you. Goodbye.